Hi, my name is Kanika, and my presentation today is on the facilitators and barriers to shared decision-making in perioperative care, looking specifically at the perspectives of anaesthetists, surgeons, and intensivists. Shared decision-making is increasingly recognized as a core part of patient-centered perioperative care. It's associated with improved outcomes, higher health literacy, and reduced decisional conflict. Despite this, implementation remains inconsistent. Most of the actual research that has focused on patients' perspectives, but the perspectives of clinicians delivering this care is not well understood. There are only 5 studies which explore perspectives of health professionals, with majority highlighting that of surgeons, and there is a lack of intensivist and anaesthetist opinions out there. So, our aim was simple: to understand the facilitators and barriers to shared decision-making from the perspectives of clinicians, specifically anaesthetists, surgeons, and intensivists. To do this, we conducted a qualitative study using semi-structured interviews with 49 clinicians across New South Wales, Australia. 15 anaesthetists, 17 surgeons, and 17 intensivists were interviewed. We used the Consolidated Framework for Implementation Research, CIFR in short, to guide our thematic analysis. Across the 5 CIFR domains, we identified clear facilitators for shared decision-making. At the intervention level, clinicians pointed to improved patient outcomes and a reduced sense of decision burden. In the outer setting, things like clinician co-location and working in a well-resourced teaching hospital helped. Within teams, a collaborative culture and open communication made a difference. And at the individual level, having proactive, health literate patients and senior leaders who actively advocated for shared decision-making was a strong facilitator. We also found consistent barriers for shared decision-making. Time pressures, interpersonal dynamics, and differences in clinical opinion got in the way. Rural and under-resourced settings struggled more, and interestingly, having a multidisciplinary team was sometimes seen as replacing the need for formal shared decision-making altogether, rather than supporting it. A surgeon-driven, task-focused culture and unclear referral pathways were also common obstacles. One theme that stood out across almost all the interviews was that informal ad hoc shared decision-making was common, but clinician felt this actually got in the way of it ever becoming standardized practice. So, in summary, there's a real gap between how much clinicians conceptually support shared decision-making and how consistently it's actually implemented day to day. Going forward, the priority isn't introducing standalone shared decision-making models. It's formalizing communication pathways that already exist, incentivizing good practice, and engaging directly the key stakeholders who make these decisions every day. Thank you.